Well, I'm really honored to have the opportunity to speak with you all today, and I'm going to talk about the most precious resource we all have, time. So we're going to loop in 18 days, and I'll tell you why it's important for this. So can anybody tell me who these two gentlemen on the left are? Charles Lindbergh. And
Charles Carrel.
Close. That's Alexis Carrel, so Nobel laureate for vascular surgery. And how about the cat? Well, so he was an organ donor. So what I'll tell you over the next few minutes is how in 2019 we would look on as ancient history back from 1935 with organ perfusion and what these two got together and collaborate, how that has led to what we're doing here at Ohio State in the Copper Lab and how it's becoming translational reality in clinical practice. So what you see on the left side, on the right side over there is some of our small animal perfusions for transplantation, and then the heart in a box, which we're starting here at OSU next month. So as most everybody knows, the gift of life for being an organ donor is phenomenal. For solid organ transplantation, one donor has the potential to save 8 lives. And for every organ that is transplanted, there is a substantial increase in the quantity of life, so number of years saved, and also the quality of life for every transplant. That's true for kidney transplant, for heart transplant, even for kidney pancreas, for lung and liver. Now, when you look at some of these statistics and some of these numbers, there are some opportunities for improvement. So you look at lung transplantation that may not have as much overall length of survival as a kidney transplant. So that's how we can make this better and try to improve the quality of the transplantation. What we see over time, and this is no mystery, the number of transplants goes up, but then for about the last decade it's been stagnant. And we say, well, why is it stagnant? Why aren't we doing more transplant? There's a lot of these people that have end-stage kidney disease, end-stage liver disease, end-stage heart disease. Why can't we do more? Well, the problem we have is we don't have enough organs. So there's some geographic constraints, there's some time constraints, as Dr. Ryan mentioned. So trying to increase the number of organs available is how we can get this gift of life going up further and further over time. Now, lung transplantation and all transplantation in general didn't really have the best history, best upbringing. So the first lung transplant was done in 1963, University of Mississippi. It was done for lung cancer, which is the exact opposite thing that we'd ever do lung transplant for now. But they did it, the patient survived, but he only did survive for 18 days. There were some really problems with immunosuppression, with the results of the transplantation. It was really in its infancy. A few years later, 1967, I don't know if you guys have ever seen this famed Time magazine cover. So Christian Barnard performed the first heart transplantation in South Africa. This is I believe he was a retired pharmacist, but he had a lung transplant or a heart transplant, did well, extubated, off inotropes, but guess what? He only survived 18 days. He died from infection, from pneumonia. So the immunosuppression, the way that the body interacts with the organ, this is a problem that we're trying to overcome. Now then back to our first two guys, Alexis Carrel and Charles Lindbergh. So back in the early 1930s, after World War I, Charles Lindbergh was a phenomenal mechanical mind, had a lot of technology or aptitude for mechanical pumps, for perfusion circuits. Alexis Carrel is a vascular surgeon. So they put their talents together and really started culturing organs. So, when Dr. Moeller was talking about what we do in a lot of the lab, we're taking cells and we're working at things at one little level. These guys went beyond that. So they're keeping an organ alive at times for long periods of time. They're trying to make it better so they can do things with it. Well, that cat is symbolic of what got them the cover of Time magazine in 1935. For some reason, they decided to perfuse outside the body a cat thyroid and kept it alive for 18 days. So there's something about this initial set of transplantation or organ perfusion where we can't overcome prolonged perfusion. The organs or the transplants just peter out, and that's how we have to try to overcome that. They had some really intricate drawings, and a lot of the stuff that was done back in the 1930s with the advent of our technologies, we're able to do now on a miniaturized level and make it portable, which is really key for what we'll talk about later. We say, well, so what? Well, we already talked about people are dying on the transplant list. there are a lot of potentially usable organs that aren't being transplanted. So if we look at lung transplant as an example, if you take 100 people who say they're organ donors, about 23 of them actually go on to be transplanted. Part of it's because of there's geographic limitations, part of it's because there's quality limitations, but there's really not enough organs to go around. And some of the suboptimal organs we may not be able to transplant because out of fear. We're held to a really high standard for outcomes and quality, and so if something's on the cusp, well, we want a little reassurance of is it going to work in a person, because we don't want to succumb them to a big operation and then have it not work. And we're really on the cusp of organ engineering. We talk a lot about gene splicing technology and some of the really sexy things that people are doing in their labs. We're right on the cusp of that for personalized medicine. Well, in lung transplantation, we are a little ahead of all the other organs in terms of expanding the donor pool. So since about roughly 2011, as a field, we've been able to take lungs, keep them alive outside the body with little miniaturized heart-lung machines, the same concept that Alexis Carrel and Charles Lindbergh did back in 1935, and keep that lung alive for about 6 hours. And in that time, we're able to transport it across the country. We're able to do things to try to make it better, see if it can improve for transplant. And when they do go on to transplant, this was a big series out of the University of Toronto, those lungs that were otherwise not able to be transplanted that we recondition, they look exactly the same 3 years out as the traditional donor. So if we can recondition them and they get better, well, we can transplant them and the recipients do really well. Well, what's that let us do? Well, what ex vivo organ perfusion lets us do, and this is what we're championing here at Ohio State, is creating organ assessment repair centers, so organ arcs. So it's a little corny, I know, but my collaborator Sylvester Black and I had this little vision of organs going 2 by 2 into the organ arc and getting resuscitated. And this is what we're doing. This with a lot of people that are in this room and in this institution. This is where we're going with reality. So you think about this from a concept. You got all these organs that may be able to be transplanted. They get put into this organ assessment center. And if they come down here and they're good to go straight out the bat and they meet all of the traditional criteria, fine. They go on to get transplanted, and that's what we do. They go on and you try to repair them. If you're able to get them better, great. You go on and you transplant them. If for some reason you can't, you see if you modify them or use those organs for research. So every organ, we're trying to utilize it to its utmost to both help recipients and also future recipients down the road. And so we're really using this as a platform so that we can assess organs, we can recondition it, and then the stretch goal, or what we're going to be doing over the next 5 to 10 years, is how we can modify them and make them better. But it took a long time for us to realize this vision. So this is Dr. Black huddling over a small animal liver perfusion, and this is us as we were doing some pilot runs in the large animal model. We really had to develop a multi-organ, cross-disciplinary, bench-to-bedside translational research program, which means what? Well, it means that when I started here in 2012, my good friend Dr. Mueller gave us space, which was an empty room. And then we had to fill it with stuff, right? So if you're gonna have a research lab that's gonna teach you how to do organ perfusion so we can get this to work in animals and we can do it in people, you've gotta figure out how to do that. And we were able to do that, where we were able to outfit the laboratory, get to the point where we're doing lung transplantation in small animals after perfusing them, liver transplantation after perfusion as well. But it took the gift of a grateful patient. There's a gentleman who had a polycystic kidney disease, who had a kidney transplantation, who wanted to give back to Ohio State. And so his gift outfitted our laboratory for the first 3 years of the research enterprise. Able to get us our perfusion circuit and build up some of our preliminary data, which then led to us getting Society grant and then a National Institutes of Health grant. And Dr. Black just got a very favorable score for his. So that's the acceleration that gets us to do these academic things, and it's really important. And what we're doing from what we're learning in the small animals is going into this. So OSU has turned this organ art, this organ assessment repair center, into reality. And this wasn't just our work. This was a lot of people being involved. This was Rafe Pollack from leadership in the chief of surgery. This was heads of anesthesia, so Ron Harder being able to allocate OR space. This was nursing staff. This was perfusionists. This was everybody. But this is what we built. So as of this month, as we finally signed the paperwork, we have a 4-organ assessment center where we've got lung, kidney perfusion, and liver perfusion, and hearts can be the one that's rolling down the road. So we've got pretty good experience for this on the lung side. So we've started the organ perfusion center for the lung in 2016, And this is George Costa, who's our first ex vivo recipient in August of 2016. He's doing great. He had pulmonary fibrosis. He's back riding his motorcycle against our better judgment, but he's doing it. He loves it. He's living his life. And we have our little Buckeye branded ex vivo perfusion system. But it's about every year, it's about a quarter of our transplants performed, and it increases our ability to give that gift to recipients by about 31%. So it's a substantial number of organs that we're reconditioning and we're transplanting. Do we save them all? No, but we're increasing that volume or that gift substantially. Well, where's the next need? The next need is heart. So heart's really got some time constraints, as Dr. Ryan mentioned. Got about 4 hours from when it comes out of the donor before it can get transplanted, and you start saying, well, the lung or that heart's not going to do well. So this is a busy graph, and I apologize. I told the team I wasn't going to do this, but if you look at 100 people that are listed, and you look at after listing, so out to about 3.5 years, where are they? Well, this number is the number that have been transplanted, so about 65% get transplanted. These over here are the ones that are still waiting, so that's about 15%. That's this purple line. And then you got these other two here, right? So what are these other two? Well, the people that were removed from the list and the people that died. You don't get removed from a transplant list if you all of a sudden get better. It means you got too sick to be transplanted. So that's 30% of people who are listed for heart transplant that we can't transplant or we can't help because of lack of organ availability. And that's the real crux of where we're trying to go with this organ arc and the perfusion system. You say, well, that doesn't make any sense. There's people that die all the time, right? How do we not have enough organs? Well, this is the challenge. So this is, if you took this big circle and say this is everybody who died, and then they had to die, or we had brain death, near a hospital, and then they got referred to an OPO, and then they had appropriate background, so they weren't have infectious diseases and things like that, and you actually able to get them to transplant. This is that small little number of organs that actually go into transplant, so it's pretty small. But the biggest barrier, we think, is geography, and I think that's where one of the biggest opportunities where we start moving into heart perfusion. So this is the Transmedics organ care system, which we're part of their clinical trial, and fortunately enough, again, this is a benefit of a grateful patient who had a heart transplant. This is a research trial, so it took a lot of infrastructure and a lot of resources to do this. But what we're aiming to do by being part of this trial, and I say this is a gift of a patient, he's able to subsidize some of the startup costs for us to get the perfusion system here and do the training so that we can start doing this clinically. But when you look at this heat map, these are organs that we've been potentially offered for transplant, and they're kind of all around the country. But we see most of where we actually are doing the transplants are those that are geographically within about 2-hour flight time from OSU. Similarly, when we look at organs that get shipped out, there's a lot of them that are kind of clustered around the Midwest here. But there's a lot of country out here where there's potential for us getting organs that we may be able to have that benefit for recipients, but we have to be able to go and get them and keep the heart alive or the liver alive or the kidney alive. And that's what these perfusion circuits let us do. And while they're on there, we can say, are they working well? Are they getting better? And this is the reality that we've got right now. So we've got our multi-organ organ assessment repair center where we've got heart, liver, lung, and kidneys. So all the 4 major organs transplanted, where we can try to resuscitate them and make those organs better and then bring them on to transplant. And then our stretch goal is, well, what can we do with 18 days? So what Dr. Black and I like to think is that if we get to that point where we can keep an organ alive for prolonged periods of time, and that takes a lot of physical resources of nutrients and things to keep that organ alive, we could change it. We could start putting in genes so people don't have to take immunosuppression. We can cut off the little markers of that organ that say that people get rejection so that maybe they don't have that problem. And then we can offer that benefit to more people long term. And so, a little, again, kind of corny, but we want to get to the point where we can say that if we're not able to take that organ and resuscitate it at Ohio State, then it's not salvageable. And we want to be able to try to offer that gift for everybody. And that's what we're doing at the Organ Arc and at Ohio State and the Copper Lab. So imagine what we could do with 18 days. So, thank you.
So hopefully this is the time when we have opportunities to ask some questions. And while we're waiting, one of the things that we'd really like to get across today is sort of the unique programs that we have here at Ohio State. And so, first question to Bryan is, if you were to go down the street to Ohio Health, or if you were to go up down to Cincinnati, or does every hospital, does every medical center have these things? And what specifically for our audience today is unique about what you're doing versus the other places?
Yeah, so I think a couple of points about that. Not every large medical center has a transplant center. So there's a certain degree of expertise and infrastructure and resources that have to have a vibrant transplant center. Some centers that are large medical centers may have a kidney transplant program, which is probably the most mature of all the organ transplanted, but there's still a lot of nuance to that. When one starts getting into heart transplant, and especially then start going to liver transplant and lung transplant, which is probably the most complex, not so much for the technical part of the operation, but all the infrastructure afterwards with the pulmonary rehab, the pulmonologist, all the follow-up. There's not a lot of places that do that or do that well. And then the perfusion side is a whole another kettle of fish. So we're fortunate enough to be able to do that because we've got a very invested clinical perfusion program. We're also able to benefit for that because Sly and I have been doing this in the lab for the last 7 years. So there are centers that have tried setting up perfusion programs and they've not succeeded because it takes a lot of tinkering and time, and not a lot of people have patience to do that when they've got other busy clinical schedules. So we are fortunate, I think, to have a couple of people of like mindset, but then able to bracket out parts of our time so we can learn how to do this, and then have vibrant clinical programs so we can do it really well.
Other questions for Bryan? Please.
What organ would you say is most lends itself to human engineering, so you no longer need a donor? And what time frame would you see something like that being possible?
So I think the thing, probably heart or lung. If you're talking about scaffolding and trying to build an organ from scratch, and there's some people doing that, probably the organ that would be easiest is, say, if you're doing like xenotransplant or transplant from an animal to a person, maybe on the kidney side or for the heart. And the problem there, if you're doing that like for lung or liver, like liver has to, if you take a pig liver and you gene edit it, so you cut off the part that people say it's not a pig, it's a person, it still makes pig protein. It still makes all the pig things that don't work well in a person. But the heart, and as Dr. Smith's gonna, cringe when I say this, it's just a pump, right? All it has to do is he'll tell you it's more, in a few minutes he'll tell you it's more intricate than that. It secretes hormones, it has hormonal interaction, it is a really complex organ, but it's just got a pump, right? I mean, for the most part. And the kidney, it just has to get rid of fluid and excretions. The lung's a little more complex. There's a lot more architecture there trying to build that one out. But I think from being able to do that from a scaffolding standpoint or from a xenotransplant or take a pig organ and make it compatible with human, it's going to be probably heart or kidney first.
And time frame, it sounds like with the complications, it's not imminent, it's something farther down the road.
Oh, it's coming.
Yeah.
Part of it's being subsidized by private industry. United Therapeutics out of Silver Springs, Maryland, and Research Triangle and Raleigh-Durham. They're putting a lot of money into perfusion and also into animal to human transplantation. There's a lot of interest in it, so it's coming. And the organ engineering and the scaffolding, like growing organs, there's a lot of interest in that too. So yeah.
I think one of the neat things Bryan touched on in the end is some of the things that we can do by combining our labs. And so some of the things that Bryan is working on, he mentioned at the end this idea of gene editing, where you might have a molecule or a DNA piece or a protein that is causing the disease. Well, it's possible now for us to go in and replace those abnormal genes with new genes that work much better. And so the idea is they might come back out and go back in once they've been fixed, which is pretty exciting. So we need to move on, but you can really tell sort of the type of talent. One thing I didn't mention about Bryan that's also unique is you can tell Bryan he's a surgeon, but he's also, you might not know, he's an engineer. So he has a PhD in engineering from Purdue, and you can tell how different parts of his brain are working together to solve really cool problems. So thank you, Bryan.
Thank you.